Good morning. Good morning, everyone. Welcome to our weekly DigiPath Digest. As you can see by the background, I'm still in Poland and I'm going to be here for the next couple of weeks. And so I let you guys, I let you arrive a few little minutes about updates. So I'm still in Poland, as you can see. Second, this is very related to what we're doing here every week. A video was published about how to set up PubMed alerts. So we are reviewing PubMed abstracts. Let me show you the abstracts as always. And those abstracts come to me automatically from PubMed, right? PubMed abstracts. And I set up specific alerts for digital pathology and AI. So in this video that I just published this week, I think on Wednesday, there is a specific tutorial how to set them up. And I see people joining. Whenever you join, please let me know that you're here and where you are tuning in from. So this video goes into the details how to set those PubMed alerts for yourself. It can be as general as generic as digital pathology and AI, or it can be super specific, like if you're a specialist in a disease or you're only interested in some specific application of digital pathology, like telepathology or just like image analysis, anything like that, then you can set these alerts for whatever you want, right? I have it for digital pathology and AI, but it can be generic specific, or it can be totally different, different area of expertise that you maybe are interested in. And I explain in that video how to do it. I have a couple of notes what I wanted to update you on today. Okay, so I was having some conversations with pretty high published scientists, and the theme, welcome Robert, so great to see you here, amazing. Joining on LinkedIn, okay, I see people joining on LinkedIn. You can also join on YouTube, Facebook, directly through StreamYard. There is a specific link where you can actually register for these things and get calendar updates, calendar notifications. And I guess we're not anywhere else today. I don't see Instagram. I don't see TikTok. I don't want to chance the internet, even though I'm in a better location. So for the time in Poland, I'm going to be limiting the number of platforms that we're going live on. But LinkedIn and YouTube are always going to be there. And good morning to India. Happy Friday, everyone. So great to see you guys. Amazing. So the theme that I decided to, that came from these conversations with various scientists, also from papers that I sometimes review as a reviewer, as a peer reviewer for scientific papers that come my way, often from veterinary medicine, veterinary pathology. I kind of decided to look at them through the lens of usefulness. How useful is it? Because like high impact factor good science does not always equal usefulness. And by not useful, I don't want to say that it's useless. It's just at the moment, like all basic sciences, like this is extremely valuable. So see, I don't want to say not valuable. It just does not have immediate application right now for what's happening in healthcare, for what's happening for patients, for what's happening for pathologists. So why is digital pathology useful to me personally? Because I can be wherever I am and keep working, right? So the telepathology aspect of it, the remote work aspect of it is super useful to me personally, professionally, and I see more people more and more joining. So feel free to say hi and let me know where you're tuning in from. I'm saying hi from Poland. It's actually 12 p.m. here right now. So, so this prism of this lens of usefulness. For me, it's useful because I work remotely, and different aspects. I'm now more efficient, so now it's more useful to me because I can be more efficient than on the microscope and different things like that. So I'm starting to develop this lens of usefulness for immediate applications, and this is something that happens in the industry. That's why I'm always so passionate about working with digital pathology businesses, because these are the entities that take the science and bring it to the market. And when it's in the market, it can be purchased and it can be used by people who do not have access to the development methods of this technology. So, for example, the Muse microscopy technology. It's a glassless way of imaging, pathology imaging. And at the beginning of the year, I had Richard Levinson on the podcast, and he was talking about different options of how can you visualize tissue, how can you image tissue and do AI on tissue without putting it on a glass slide first. And I'm like, wow, that would be super useful. So there's a company called Muse Microscopy that actually purchased this technology, put in additional like 3 or 4 years of work into making this idea, this concept, this revolutionary thing from the publication and from the research group into a product that somebody can buy. And so I love it. That's useful to me. So now I see that we have enough trailblazers joining. Let me know where you're tuning in from, and we're going to dive into the papers of today. So we are starting with diagnosis of Hirschsprung's disease by analyzing acetylcholinesterase staining using AI. So this staining is going to be an IHC staining. This is a group from Germany, publication in Journal of Pediatric Gastroenterology and Nutrition, probably. What happened in this publication? So this Hirschsprung disease is defined by the absence of ganglial cells in the rectosigmoid colon, in the colon. So there are no nerve cells there. And the diagnosis is rectal biopsy. And what do they diagnose there? They diagnose lack of ganglia and the presence of cholinergic hyperinnervation. So more of these other nerves. And that's why they're staining for the ACHE, acetylcholinesterase. So unfortunately, depending on the method of the rectal biopsy, the quality of specimens and the related diagnostic accuracy varies substantially. So depending on the method of biopsy and quality of specimens, that's kind of like applies to everything, right? If you have bad quality specimen, then your diagnostic accuracy may suffer. But they decided, okay, let's do it with software. Maybe it's going to be less variable and it's going to be better. So software-based identification of the staining cholinergic hyperinnervation in digitized histopathology slides was performed here. They had 190 samples and they stained it with ACHE. And they used Halo and QPath, which are openly available. So Halo is a commercial software by Indica Labs. QPath is open source. You can download it for free. But basically, image analysis software. And what they did, they first decided to detect the staining of the mucosal layers of the intestinal wall. And then they checked. So this marker stains the nerves, but it also gives some background, right? So But the results were that the area of the positive staining was greater in the Hirschsprung disease patients compared to healthy individuals. Do you need image analysis for that? I'm not sure, but they used it. Okay. And it depends, like, how subtle the differences are. If it's just a binary, or like if it's a lot of area, then you can do it visually. If not, then you want a software. And they say that software-assisted machine learning analysis of ACHE staining is suitable to improve diagnostic accuracy of Hirschsprung disease. How useful is it? I cannot answer this question yet. I don't know. Maybe it's useful if you can like do it unsupervised, which probably is not the case. If the differences are subtle, then it's useful. And welcome, Monica. Great to have you in the live stream as well. So yeah, I don't know how useful that is, but it was published. And the advantage of something being published is it's out there, and somebody else who like sees it can take it to the next level. And so I'm glad it was published. The next one is graph learning based model for automatic diagnosis of Sjögren syndrome on digital pathology images. I actually once was part of an image analysis evaluation of clinical trial samples for Sjögren syndromes, and we worked on immunofluorescent images. We had to stain different types of immune cells and then quantify them, which was not possible visually. So image analysis, well, no, I was not confident in my visual evaluation. The more markers you have, the more difficult it is. But let's see what they did. Graph learning. So graph learning is a specific machine learning method that bases stuff on graphs. This is in Journal of Translational Medicine, a group from China. And let me put this bigger. And what happened here? So what is this Sjögren syndrome? Rare autoimmune disease affecting adult females characterized by chronic inflammation of salivary and lacrimal glands, so the tear glands. And they're then dysfunctional, and you have immune cell accumulation there. And the diagnosis of this syndrome is based on histopathological evaluation of salivary gland tissue. And obviously it has limitations. And so what happened here, they had 100 labial gland biopsies, so from the lip, and there are like little salivary glands. And they made whole slide images, and they used this method called the method cell tissue graph-based pathological image analysis model. That's a complicated name. CTG-PAM. What happened there is this CTG-PAM leverages connected component analysis techniques. Connected component is the keyword. So this is like the graph component, connected component in the cell graph structure to perform diagnosis based on lymphocyte counts. And it outperformed traditional deep learning methods, and the area under receiver operating curve is 1. When I looked at this, is like, it's never 1. What's going on here? So they said 1 for the internal validation data set and 0.8 for the external test set. So like on the data kind of they trained on, it was very accurate. And they say that this new graph method is reliable method for Sjögren diagnostics. And this graph structured. I missed one component. So why is it important that it is graph? Because they captured relationships. They captured here this single cell features, then cell features, and cell tissue features. So they captured different relationships between those cells, and that's why this graph methodology was employed. And hi to India again. What time is it in India? Let me know. It's 12:15 here. You might hear some dogs barking. And these are my cousin's dogs. Oh, I love this one. The third one is language discrepancies in the performance of generative artificial intelligence model and examination of infectious disease queries in English and Arabic. I love it because I used to be an interpreter. So after vet school, I already started working as a vet. So I don't know if you guys know that I actually worked as a vet treating animals, and I was in a cattle practice, in a large animal practice. But like in addition to that, I still kept in touch with my university. And whenever they were organizing a conference where English speaking lecturers or German speaking lecturers would come, then they would employ me to interpret. And I would do simultaneous translation, like from the booth with headphones, or and consecutive, where you like stand next to the lecturer, and you basically, they speak one sentence, then you speak one sentence. They speak one sentence, and then you stay there, stand on the stage next to them. Like, I didn't like prepare any of this presentation, but I'm presenting all of it. Anyway, so I have like a special relationship with language learning and translating and interpreting. So, and that's why I was interested. What this group from Jordan, the group is from Jordan. Let me make it big. Did and so they checked. Okay, is the English Chat GPT or large language models, are they good, as good as the Arabic version? And before we dive into, I'm gonna say, so it's 350 in India, and welcome Madhu, so great, from UK, fantastic. It's amazing to have you here, guys. So okay, so why did they want to do it? I suspected why they wanted to do it. They say they want to check to ensure equitable access and accuracy of information in multilingual context. So they're checking, okay, is English as good as Arabic? If somebody doesn't, I did some research here that disappeared. I don't see it. That's okay. Maybe I can open it in another one. That's okay. So the methods, the study employed the metrics checklist for the design and reporting of AI-based studies in healthcare. And I found exactly what this metrics checklist was. It's a specific checklist to evaluate AI technologies for healthcare. If you give me 1 second, I think it's relevant enough to check it. Let's see. Can I do it? No, because I'm going to disrupt our live stream. But anyway, there are two tools here, Metrics and Clear Tool. And I had this like acronym spelled out for you. Maybe in the podcast version, there's always a podcast version of our live stream. And in the podcast version, I can basically like speak over. So I can speak over and tell you what that is. So if you want to get back to it, then you can hear it in the podcast. But let's move on with this paper. So they use this metric checklist. And there is an official checklist how to check the suitability of those AI-based studies in healthcare. And they asked different models. What were these models? Of course, our friend ChatGPT version 3.5, version 4, then Bing, Bard. And there were queries. They had 15 questions about HIV, AIDS, tuberculosis, malaria, COVID, and influenza. And we have people watching from Kenya. Amazing. Thank you so much for joining from Kenya. So there's going to be a paper about Africa as well. So stay till the end, and maybe you can comment on this in the chat. That would be great. So we asked ChatGPT 15 questions, and there were 2 bilingual experts using a validated Clear tool. So this Clear tool is another tool for checking how the language AI specifically, how accurately it answers healthcare related questions. So I'm going to have the deciphering of this acronym for you in the podcast. And what do you think? What do you think happened? You probably can already see it. Oh, I cannot use the. Okay, you can see it in the abstract. Well, English was better than Arabic. I kind of suspected it. Why did I suspect it? And it's my suspicion because or at least like the main, I assume, probably all of those that they checked, all of the models that they checked were developed in the US by US companies. So ChatGPT is OpenAI, this is US. Bing, I think it's also US. I don't think any of those can correct me if I'm wrong, especially if you're from an Arab-speaking country, and I am here, show me my ignorance, but I think all of them are in the US. So my suspicion or my assumption is, and please always correct me if I'm wrong, if this assumption is incorrect, that those models were mostly trained on English language. And then there's this translational capacity. So, but let's go back to the paper. These are my assumptions and my thoughts. So comparing AI models' performance in English and Arabic, variability was noted. English queries showed consistently superior performance. And there's like what was leading. BART was leading, then was Bing, ChatGPT 4 and 3, and the same trend was observed in Arabic without statistical significance. So there was the scores for English in the Clear tool were higher, and basically English outperformed Arabic except for flu queries. Maybe there's a lot of material about flu in Arabic in Bing and BART. And the AI model's performance in English was rated as excellence, whereas in Arabic only above average. And there is a problem, or there is a conclusion. Disparity in AI model performance was noticed between English and Arabic. And the language variation can negatively impact the quality of health content delivered by AI models among native speakers of Arabic, or probably native speakers of any other language than English. And this issue is recommended to be addressed by AI developers with the ultimate goal of enhancing health outcomes. Yes, I think this is useful information. Does it surprise me? Not really. And it's gonna be the case probably, well, that's again my interpretation. It's gonna be the case for any other language than English. If the model was developed in English, then probably data in English was the majority of data it was trained on. And I think the AI developers that would have to help would be the native AI developers. Let me know if you have any thoughts on that, because this is also a topic that is kind of on the verge, or not on the verge, but like ethics, health equity, and policies and things like that. So feel free to drop me a comment about that in the chat. And in the meantime, we're gonna move on to the next paper. So this one I think is super useful. It's like different because we're not talking cancer, we're talking about diagnosing fungal keratitis. And this is scientific reports from the science portfolio. Fungal keratitis, so inflammation of your cornea by a fungus via in vivo confocal microscopy. And I'm like, that's like, when I think about, when I prepare these papers for you, I'm like kind of challenging my thinking as well, because I'm like, confocal microscopy, that's like very sophisticated way of microscopy. Why don't you just look at the slide in light microscopy? And oh, Monica is happy that it's not only oncologic applications today. I think there is a lot of publications about oncology stuff, and it kind of does disservice to the other areas of pathology, because everybody who is not a pathologist thinks pathology is only cancer. But no, it's also fungal keratitis. So let me walk you through my pretty my way of thinking about this. I'm like looking confocal microscopy. To me, it's like, oh, it's such a sophisticated technique. Like light microscopy is so much simpler. And then I went actually into this paper and I checked. Oh, so this is, by the way, so this is a group from China, from Beijing, and oh shit, I made notes. But anyway, the note I made here by the abstract was, how do you normally diagnose it? So to put it on the microscopic slide and use light microscopy, you know what you have to do? You have to scrape your cornea. That's like not fun. I'm like, yeah, how about you think about the patient, girl, instead of like what kind of microscopy is easier for you to use. So that was my first thought. So first you scrape the cornea, then you can look at it under the microscope, and then you have to culture the fungus, and that takes a long time. The fungi, they grow a lot slower than bacteria, so I estimate like a couple of weeks. So anyway, what happened here is that in vivo confocal microscopy has been widely adopted to guide the fungal keratitis diagnosis. And they developed a deep learning framework for diagnosing this with confocal, in vivo confocal. And I have a comment about the previous paper with language. Kemp, I'm going to show it in a second. So let me finish this one. They have a method, a two-stage deep architecture for diagnostic predictions based on both image level and sequence level information. Image level, so what we see in the microscope. Sequence level, they developed like a super quick way of sequencing, some snapshot sequencing. And so they have these two data points, and they had a very, very big data set of images, 96,000 over 632 confocal images, and they used them, and their results were comparable or better than experienced ophthalmologists. So the network can provide image level, sequence level, and patient level diagnostic suggestions for physicians, and the results show great promise for assisting ophthalmologists in the diagnosis. So I think this one is useful because, first of all, it's in vivo. So you like take this image and it's happening on the fly. It's not whole slide image. It's a snapshot of where this fungus actually is. So you see the hyphae. You know, I don't know exactly the diagnostic workup of the fungal keratitis, but I imagine you could have non-doctors like go through the workup and then have the AI run on it, and then the doctor shows up only for confirmation or something, some kind of like a funnel approach. So I thought it was useful. Let's look at the comment about the language. So Kemp, language would play a huge part. Models are linguistic, and Arabic is a right to left script. So the model would not only have to be multilingual, but multidirectional. Also, Arabic is not really a language. It is a large set of dialects. I assume so this was from Jordan. So I think, and Arab-speaking people, please correct me if I'm wrong. I think like the high Arabic or the international would be the one from Egypt. And then, of course, you have dialects, each with with set of different words, so very challenging for LLMs. Yes. So do you think my assumptions of the model not being trained on enough Arabic data is correct? Let me know what you think about that. Okay, let's go to the other papers. I have too many. I have too many. It was supposed to be like a half an hour thing, but I always get 10 and I don't know which one to like not discuss. Okay, here we have advances. This one is going to be fast. Advances in estimating plasma cell in bone marrow. Well, a comprehensive method review. So this was a review, and I just wanted to, I kind of like screened it for, where was this? In African Journal of Laboratory Medicine. Okay, interesting. And this was a group from Cape Town, South Africa. If there is anybody from South Africa, say hi in the chat. And so how can we quantify plasma cells in bone marrow? It is crucial for diagnosing and classifying plasma cell neoplasm. So we're back to oncology, but that's okay. We had a lot of infectious stuff. So we can do Romanowski stain in aspirates. So this is just on slides. You look at smear. Then we have immunohistochemistry, flow cytometry, and radiological imaging. And the one that is kind of emerging to be the gold standard, even though they say there is not really a gold standard, is the immunohistochemistry, CD38 or MUM1. CD138 or MUM1. And if you have something stained with IHC, you can quantify it with image analysis, and now image analysis is AI powered, so we can do it on whole site images, and this is promising. Yeah, that was a quick one. Basically, how can you do it, and can you use digital pathology as well? Yes, and it seems to be one of the most promising methods here. So, without further ado, let's check. And the validation of AI-assisted thin prep pap test screening using Genius digital diagnostics system. What happened here? This was published in Journal of Pathology Informatics, so the official journal of Digital Pathology Association. And this Genius is from Hologic. So they have a commercially available algorithm for checking pap smears. And the group who did this is Liren Pantanowitz and Richard Cantley et al. But Liren Pantanowitz is kind of famous, so I recognize his name. And that was Michigan Medicine and Pittsburgh. I think Liren is at Pittsburgh right now. So what did they do? They compared the performance of Hologic to traditional manual light microscopic diagnosis of thin prep pap test slides. And they had 319 of these. And concordance with the original diagnosis was significantly different by digital and manual. Digital first, manual light microscopy. And keyword concordance with the original diagnosis. My mind goes like, who says that the original diagnosis was correct? But that's, a different story, a different question. But basically, this is what they compared to. That is fine. And there were some discordances, right? Not discordances, but how did they call it? Different, significantly different. The concordance was different. So, and they implemented different systems, different diagnostic systems. So, exact Bethesda system diagnostic, it was, where am I? 61 versus 55. Sorry, 62 versus 55%. So 62 is the digital, 55.8 is the light microscopy, the visual. Then we have condensed diagnostic categories, and we have 76 for digital, 71 for non-digital. And then we have also condensed diagnosis based on clinical management. And here we have 71 versus 65, digital versus non-digital. And also time to evaluate cases was shorter for digital. So not only did our evaluation study demonstrate that AI-based digital pap test evaluation had improved diagnostic accuracy and reduced screening time, but the participants reported a positive experience using this system. It's like this last sentence, but it is so important because this goes back to the discussion of usefulness. Like, okay, let's say you have something that's super accurate that nobody wants to use. They will just like defend themselves from using it. So the user interface, user friendliness of those digital tools is super important, and participants liked it. So this is fantastic. And I have follow-up comments about our language discussion. Let me see what else I have for you before we embark on this. Yeah, we need to talk about breast cancer. So there's another paper, advancing. No, we have breast cancer, this, and we have the African telepathology. So if there's, I know there's somebody from Kenya, so feel free to chime in for this one. So Ki-67 hotspot detection in breast cancer, comparative analysis of automated digital image analysis algorithms. Are we looking at two different algorithms? And this is a group from Groningen in the Netherlands, where I lived for a year when I was 16, not in Groningen, in the Netherlands. And this was in histopathology. And again, I was reading this through the lens of usefulness. So you probably will know by my face expression what I thought about this, but maybe I misread something. So this study compared the clinical performance of Ki-67 hotspot detection and scoring digital image analysis algorithm based on virtual dual staining and deep learning with manual Ki-67 hotspot assessment. So we have two different algorithms and the manual. And manual, as far as I know, you have to count like 500, and MD pathologists, please chime in, 500 cells, and then you calculate the index. And the cells that you calculate, positive and negative cells, that's how you get the index, and they have to be in the tumor tissue. So, obviously we are staining immunohistochemically for Ki-67. This is a proliferative marker. And the conclusion was that automated Ki-67 hotspot detection and analysis correlated strongly with manual assessment. I hope it did, and provided higher PI, so proliferation indexes, compared to manual assessment. So why? We probably would need to read the paper, but there are a couple of options why. One is the people who were manually counting it counted less, and the software picked up more. The other one is software overcounted. I'm glad it correlated. Yeah, so, and they say that use of deep learning-based algorithms may allow clearer Ki-67 proliferative index cutoff values, thereby improving the clinical usability of Ki-67. So as far as I know, there are several Ki-67 algorithms that are cleared for use. And that was actually one of the first image analysis algorithms, not yet on based on deep learning. It was on the classical computer vision methods. And it has been there forever. So I was surprised to see this kind of paper published, but I guess that's okay. There are differences. And let's talk about Africa, and then we go get back to the discussion about languages. So the state of telepathology in Africa in the age of digital pathology advancements, a bibliometric analysis and literature review. So, and this group is from Tangier, and they checked what was published about telepathology. And it's funny because last year I was speaking at the American College of Veterinary Pathologists conference, and I did literature search about static telepathology, specifically static telepathology. And I like found few papers. I didn't find too many papers. Then I was kind of like comparing it. Okay, this is what you will find in literature. And I was not restricting my search to underserved regions or to Africa or to any geography. But most of these papers came from Africa, Asia, like non-Western countries. Anyway, and when I looked at the number of citations, and then I contrasted it to how static telepathology, so digital images, is used for education through social media. And I showed like different accounts, including mine, which I don't use too much pathology images. I talk more about digital pathology, but there are like online educators in the veterinary pathology space and in the MD space even more that have accounts with like tens of thousands followers who want to learn about cytology, about pathology on static images through social media. So there's definitely a huge impact through the non-traditional channels. And here, going back to our paper, we are talking about what's happening regarding telepathology in Africa. So they say it's a vital tool. It has significant promise for enhancing pathology services in Africa. And they conducted a methodical search in PubMed. And when I saw that, I'm like, you should have used undermined.ai, which is this other tool that I think I mentioned to you one time. We were like, I was struggling to show you how it compares to PubMed, but we will have a webinar. The webinar is going to be scheduled this week in 2 weeks with the founders of undermined.ai, which is like a more intelligent search engine that rates the relevance of papers than PubMed that is only keyword based. So anyway, that what happened here, they did the PubMed search and they found 119 studies, and then they had to go in, only 47 met the inclusion criteria. So I think they would not have to do it if they used Undermined. So they say that there is a growing interest, like it's kind of vague, growing interest in telepathology, but obviously we have challenges. I mean, people in Africa have challenges, and those challenges are infrastructural inadequacies, shortage of skilled professionals, that's a global challenge, not specific to Africa, regulatory hurdles, global as well. And they say that the indispensable role of international partnerships is advancing telepathology in the region. So I love this technology. I mean, I work with it every day because I just like have my slides virtually. Anytime you have the slides virtually, that's telepathology, right? But you can do different types of consultation. And they say that this review proposes a strategic pivot toward leapfrogging, an approach that allows Africa to skip traditional developmental hurdles by directly adopting the cutting-edge technologies. So this leapfrogging, I've witnessed that in Africa. One time I visited Africa once, and I went to Ethiopia. And the example was that everybody had cell phones. I mean, everybody in Europe also had cell phones. But in Europe and in the Western world, before the cell phones, you had those normal phones, the cable phones. This never happened in Africa, or at least happened to a negligible extent because the infrastructure wasn't there. So they basically leapfrogged this cable technology and went straight to the satellite mobile phones because that was feasible. So you don't have to like take it step by step by step. And I'm seeing this in the AI development as well. I'm kind of like now in the mode, okay, if something is like, if you hit the wall with something, like don't try to push through this wall. Wait till somebody develops the next technology. And that's kind of what it looks they try to adopt in Africa. Okay, so let's go back to our discussion. I don't know how I can mute myself to cough a little bit. I don't know if I muted on time. Okay, so so I missed whether the model was actually trained on Arabic. So this is not in the abstract, and I didn't go into the paper, so that was my assumption. Or the queries were translated to English and into an English trained model. So the models were ChatGPT 3.5, 4, so I assumed they were on English, right? And the wording here is something that I find a bit misleading. Oh, that's Chi-67 detection is not Chi-67. It is a Chi-67 simulacra. What is a simulacra, Camp? Let me know. The conclusion may be very useful, but the lacks terminology, and this is so. That's kind of the problem with the abstracts. We review the abstract. Sometimes if I need to explain something, I go to the paper ahead of time, but I kind of don't go beyond the abstract in this session. So maybe sometimes it's more my opinion than a conclusion from the paper, which I will address. I should address more. I think I should address it more. And the leapfrogging idea, same as cell phones in the region. Yeah, there's a big opportunity, but no cash to build that infrastructure. Yes. So what I'm seeing or hearing about is like, and that's why I'm saying that when I look at the papers through the lens of immediate usefulness, it doesn't mean that the research, like for example, foundation models, like where is it going to be deployed? Like, I don't know, somewhere where there are a lot of computers, probably not in the nearest histopathologist office here in Poland, where I am right now, right? But what can happen, and what already happened with the non-huge models, the normal image analysis applications, you kind of developed it on whole slide images or like on a lot of data, you compute it, and then you kind of thin it, strip it so that you can deploy it in the microscope. So you put the camera or you like however you want to capture images. And that was what I was researching in that ACVP presentation about the static telepathology in under-researched areas. There is no way there is going to be a scanner. Maybe there's going to be one for like a lot of like in the main institution, but it's not going to be something that like a private pathologist can buy for themselves to put on the desk. Unlike in the US. In the US, you could get like a one slide scanner for $15,000. Like it's a normal price of equipment. You can have a scanning camera for like $12,000. It's like it's not little money, but it's normal price that a professional having oh yeah, we have comments. Okay. Remember, deploy in microscope for when we meet in Florence. Lots to address. And so I am so glad Kemp is here. He is my person that like brings me always to the back to like being accurate, back to fact checking, back to exploring the things that I don't understand because it's not in my area of expertise, like optics. Like he's an expert in optics, so so he knows things. And we're going to meet in person and we're going to discuss and we're going to have a podcast. He already agreed that he's going to be on the podcast, but I don't know when yet. But basically, we have discussions offline as well, and he keeps me in check, which I very much appreciate. So that's it for the papers today. To finish this comment that you can like do this huge resource intensive science, and once you have the insights, you can take the insights and figure out how to benefit from the insights in a in a way that consumes less resources. So while I'm reading the papers or abstracts or whatever, I'm like, okay, how is it useful for me right now? How is it useful for the patients right now? where I am, like in how is it useful for my next whatever, like appointment. But obviously, healthcare and research doesn't work in such short-term fashion. So that's why I think reviewing those papers on a regular basis still makes sense. And commenting on the price, 15K would often be a great price here in Europe and USA, but in many low and medium income countries, 5K is about the limit. It's a real challenge. Yeah, so like this is inconceivable money in places where you don't have so much money. Whereas in European Union and you know, if you look at other medical equipment, this is like in the US and in Europe, right? It's lower end of the spectrum. So obviously, price discussion is also like resource. It's as deep and broad as like discussion about resources around the world. I would love to thank you for joining me today. And we will be discussing papers next week, probably from the same office of my cousin. Thank you so much for taking part in the discussion. Thank you so much for joining, saying hi from different parts of the world. Before we finish, I would love to ask you to go and visit that video. So at the beginning, not everyone was there. So I start immediately at 6 a.m. or 12 p.m. here, and it takes you like about 5 minutes to join everyone, and some people join at the beginning and then stay till the end, some people join in the middle. So if you missed that, there is a video published how to get those PubMed alerts to your inbox, then go to my channel, YouTube channel, Alexandra Żuraw Digital Pathology Place, and check out the most recent video, and you can set your own alerts for this very, very rare occasion that you never want to live through, but sometimes you might need to miss the DigiPath Digest, so then you can read those abstracts in your own inbox. And I'm gonna talk to you in the next episode. Have a wonderful day.